Welcome and thanks for joining us. Our guests today are Dr. Bart Harmon, the president of Clinical Informatics Experts, Stan Huff, the chief medical informatics officer of Intermountain Healthcare, Dr. Kaveh Safavi, the healthcare global managing director at Accenture, and Jim Traficant, the managing director for Accenture Federal Services and president of ASM Research. It's great to have you all. Our topic today is healthcare, healthcare informatics, healthcare information technology, and one of the biggest issues that comes up between the Veterans Affairs Department and the Defense Department, and between those two and private health industry, is the issue of data interoperability. Where do we stand now? What's going on with interoperability? What are the issues? Kaveh, why don't we start with you?
Sure, Tom, thanks. Sometimes that seems like a very technical issue, but when you really think about it, none of us get healthcare in isolation. The Department of Defense, for example, at least half of the care that the fighting force receives has to be provided by other institutions in some fashion. So there has to be some form of the ability for these organizations to share information, to share handoffs, to make sure that men and women are getting the care that they need and they're getting back in to the tasks they need as quickly as possible. All of those come down to these institutions working together. We characterize that as a concept of interoperability, and then you start to have the conversation about how exactly does that happen. And then we have conversations about how does this happen technically, how does this happen from a language meaning culture perspective, and how does this happen in terms of businesses and business models? All of those are part of the story. And Stan, you're the informatics officer, so I guess this goes beyond just name, address, and name of disease when you're talking about medical data.
It really does. It's trying to exchange all of the meaningful aspects of a patient's record, which certainly does start with disease names and other things, but it's also appropriate names for laboratory tests and all of the drugs, appropriate names for the therapies that patients can receive, and so it really is comprehensive of all aspects of medicine that we're trying to create interoperability.
All right, Bart, I'm going to jump over to you and ask, what is the status of interoperability just within the industry itself, setting aside government for a minute?
The status is inconsistent. In some places you have moderately good interoperability. In other places it's not as great. And just a marker is that the need for interoperability across DoD, VA, and the commercial health space has increased significantly since about 2003. It's been important for a long time, but we may want to dig into that a little bit further at some point. The need has really escalated because of the nature of the injuries, the survivability, the severity of injuries, and the length that people are recovering. The need for interoperability is remarkably different now than it was before 2003.
Okay, and Jim, you deal with the federal segment a lot, and so I guess two questions. One, is federal providing the leadership that it says it's been wanting to provide since 2003, 2005, and are they actually there? And how? And also the second question is, what's the state of interoperability between the DoD and VA now? Because you hear a lot of news, but not a lot of facts sometimes. I guess that's an odd way to put it, but we don't really know.
Yeah, thanks, Tom. When I think about interoperability, I come at it in multiple dimensions. Probably the primary one is as a patient. My goal would be to see people walking into a hospital with their information showing up when they do, as opposed to carrying a large box to try to describe what condition it is that they need addressed. When you look at the unique place we are in federal, both DoD and VA are going through this once-in-a-generation modernization of their clinical benefits and back office systems. It's one thing for one department to be doing it, but both are doing it concurrently. And so this is a unique opportunity, and I think a great chance for the federal government to lead in the transformation needed for the nation. And I think both have unique approaches to it, but it's a priority from the White House into the departments about making sure DoD and VA are connected, and I think they're making a lot of progress.
And so, Kaveh, how would you characterize the issues? Because you can go up to the cultural level of organizations that have trouble seeing eye to eye. That's VA and DoD. Then there's semantics, and there's data elements. It gets very deep into detail. And so how do you attack all of that?
You have to attack it from both the top and the bottom, quite honestly. The businesses that have been created to solve these problems were all created at different points in times with different technology standards. So at some level, someone has to do the work of actually connecting them together. That's very much a technical piece. What we often find, though, is that the willingness, the motivation, the economic basis for doing that comes from the top. It comes from the leadership. It comes from the organization's willingness. And the reluctance to share sometimes comes from a true sense of trying to protect your own constituents. In some cases, it comes from more of a sense of control. And in some cases, it actually comes from a reality that an organization has made a significant investment, and their expectations for a return on investment require that they have a particular set of business partners. And if they suddenly change that, no one would make them whole on their original investment. It's a legitimate issue. But I think right now you're starting to see that as we think about the health of the citizen, all of these issues are converging in a conversation that is both one about public good, but also one legitimately about how private companies are going to operate.
So maybe that's the best point of view to attack the problem, is from the point, as Bob McDonald says he's going to do at VA, look at it purely from the veteran standpoint, looking at it from the patient or consumer or user concept idea or point of view.
At the end of the day, that's the only reason we're all here. So I think that's probably a good common denominator.
And Stan, there's also the issues of big and small. I mean, there are large healthcare networks around the country, some of them as big almost as VA. And yet there's thousands, millions maybe of small providers who may or may not have records or records that are as sophisticated systems as the big healthcare providers. What about that size disparity, organizational issues?
When you talk about interoperability and the benefits that can accrue, the difference between big and small is really important, because at Intermountain, for instance, we feel like we're in pretty good circumstance. We have 1,000 people basically who are working in IT, and but it's a minority of patients in the U.S. that are being taken care of at Intermountain Healthcare or Vanderbilt or Columbia or Mayo Clinic, the places that are known for being sort of on the cutting edge of IT. Typical Americans are being taken care of in 200 or 300 bed hospitals, community hospitals, and the ability to oftentimes they're lucky if they have someone who takes care of the physical facility for the machine room, much less an MD or PhD trained informaticist to try and implement the systems. And so I think we have to constantly think how we get the technology from sort of leading institutions, and how do we make that scale into small institutions. And it's a challenge, and we have to think about doing cloud-based things or doing other kinds of things that don't require a large local staff to support and maintain that technology.
Sure. And Bart, talking about looking at this issue from the patient standpoint, there's also the provider standpoint, because they're the ones that have to do the data entry, if you will. And a lot of clinical providers, doctors, nurses, and so forth, find that it can get in the way of when confronted with an electronic health system. What are the issues there? How do you overcome them?
One of the challenges is if interoperability is pursued as an end unto itself, you can go to the other extreme of too much information that's not poorly organized and not easy to navigate. So there's a happy medium of pursuing the interoperability that needs to be semantically interoperable when necessary, that needs to be human readable when necessary, and that's easy for the provider to navigate. If they just get buried with a lot of information from outside organizations and they can't find it, then in some sense they're liable for information that they could have found, but it's practically impossible for them to actually dig it out of the mountain of information that's available to them. And that's where decisions about to what extent do we want to make information available, not available, semantically interoperable so the machine can compute on it, so to speak, and serve it up to the provider in very intelligent ways, including alerts and reminders, and to what extent we just want to make it readable. And those are not easy decisions. They're decisions about how do we want to practice healthcare, what information is useful in what formats, and blindly pursuing some given level of interoperability without thinking about why you want it to be interoperable in that way can actually be counterproductive.
So this is not just a matter of user interfaces and data fields all connecting to a database. There's
Right.
real practice types of questions that have to be answered before you can do that.
In general, we need more interoperability, but it's not a blanket be-all, end-all goal. It needs to be done in a well-thought-out way, in my opinion.
All right, and Jim, I wanted to ask you, the DoD is looking for a whole new system without getting into RFQ and RFI and contracting issues. Is it, in a general way, what should they be looking for the next generation of electronic healthcare record, notwithstanding that VA might be a bidder on that? But, again, aside from specific companies and so forth, what should they be looking for in the large sense?
The DoD has a mission to deliver. I love the leadership with General Robb, and he's made the statement, this is an opportunity for the Defense Department to lead the country on interoperability. So they're recognizing modular, open system, connected, and appreciating the framework that the DoD has a mission to serve. So readiness of the force is instrumental, it's foundational. But they also have, roughly 8 million others that the Defense Department provides care for, that they may get that care in the private sector. They need to make sure that information can flow. As part of the defense mission, they're working with NATO and other countries. And when you think even the diplomatic focus of the DoD, healthcare is one of the areas where the country turns to the Defense Department to help in areas where there's a crisis or some opportunity that only the U.S. and the DoD can go in and enter and help deliver healthcare. So there's a need even for interoperability in the diplomatic settings. So the leadership and the opportunity there, I think, is great. And also the commitment, and the DoD has been very clear about this, for DoD and VA to also be able to share information. The mission continues as you move to veteran status. And then to credit the secretary over at the VA as well, when he announced My VA, this notion that we're going to organize from the patient and think about how we deliver care seamlessly, where we're going to focus on the patient, not the technology. And I think that's the goal where we're headed with interoperability.
Okay, so Dr. Safavi, we've talked about culture, healthcare practice itself, and the workflows involved there, and legal issues, I guess, as well as clinical issues. There's also the data, the semantics, and the interoperability. And then there's the financial question. So as VA and DoD get towards this next generation, do you think that there's a chance for all of this to kind of congeal in a way that starts to actually drive healthcare costs down? Because nothing else seems to have been able to do that so far.
Right. It's always been one of the expectations is that better healthcare is less expensive. We can take out duplicative tests, for example, but more importantly, doctors can get to a diagnosis faster if they have the information they need. And to some extent, patients who really need to make their own decisions are going to be much more empowered to make their own decisions if they have all the information they need to make it. Because part of the equation here is that patients participate in their own care, and they need the facts too. So I think that one can't conceive of a healthcare system that is as safe or effective or affordable as possible without the underlying technology. That said, we know for a fact, there's plenty of real-world evidence that technology by itself is necessary but not sufficient to get to those ends. So I think there's a recognition here that this is an investment. It's a requirement as part of the journey, but it's not sufficient by itself. Other things will have to happen as well to realize those goals.
And Dr. Huff, when you look at all these little healthcare records providers that individual clinicians might have versus what the big providers have as more sophisticated systems, do you see maybe a shakeout coming perhaps of the because there are lots of providers of electronic health records. This actually goes back 40 years in reality, even though it's only become a national attention thing for the past maybe 10 or 12 years.
I think so. I think we'll see consolidation of a lot of those small organizations. There's, I think, pretty substantial competition, and that'll lead to mergers and acquisitions and other things, and I think we'll see consolidation. One of the things that's been touched on a little bit that really has to do with the motivation for interoperability is around the fact that we have misaligned incentives. And what I mean by that is that it's better for the community, obviously, if I'm seen at one institution, I go to another institution, and that institution can see what tests were done and what kind of diagnostic studies were done, and understand that. But in point of fact, right now, and so there's the benefit that we've talked about, that tests wouldn't be redone and we would save that money. Well, the way our incentives are aligned today, that's not true. If they come to my institution, I actually make more money if I redo the test. And so there's a substantial misalignment of incentives that you need to overcome that have much more to do with the things that Kaveh has talked about in terms of the business motivations for doing data exchange, as opposed to what would make sense as a community and as a nation. So.
All right, well, we'll pick up on that. It's time to take a break. Our guests today are Dr. Bart Harmon. He's the president of Clinical Informatics Experts. Stan Huff, the chief medical informatics officer of Intermountain Healthcare. Dr. Kaveh Safavi, the global managing director of health for Accenture. And Jim Traficant, the managing director for Accenture Federal Services and the president of ASM Research. I'm your moderator, Tom Temin. This is Industrialized, Interoperable, and Insight-Driven Federal Health Panel, sponsored by Accenture on federalnewsradio.com and 1500 AM.